Okay. So this is chapter 38 in your Boyd text. It's very well written, and I definitely encourage you to read this chapter. All right. So we are going to start with a poll. So I will go ahead and launch that. Okay. We're still shy, just a few people. I'll wait just a minute. And so today we're going to be talking about the neurocognitive disorders, and these include disorders that are positive for delirium and for dementia. Okay, so delirium is acute confusion, and there are many causes of that, as you can imagine. And then dementias, they're categorized in DSM according to major and minor. So the main dementias that we will talk about are the most common ones, which are Alzheimer's dementia. But there are several other types of dementia that you're very likely to see. So we'll touch on those as well. We'll also touch on amnestic disorders if I do have time, but that is also included in your chapter for reading. All right, so I'm going to go ahead and launch the poll. Okay, so go ahead and take that. They're just 4 questions, and let's see how you do. Do y'all see the poll?
Yes.
Give you about 30 more seconds. All right, I'm going to go ahead and end the poll. And let me just share the results so far. And we'll go over these throughout the lecture, and then we'll retest at the end. So from looking at the results, it looks like you all have some understanding of delirium and dementia, but maybe some details need to be clarified. So you can see these results, and like I said, I'll go over these over the course of the lecture. So most people feel that potential causes for Alzheimer's be genetic factors, other an excess of choline acetyltransferase, its effects on acetylcholine, that dementia comes on, that delirium comes on more insidiously. So you do have to know what the word insidiously means. That's more slowly and gradually and subtly. So many of you feel that lifestyle changes have been thought to decrease risk of dementia. And then lastly, you thought that this person that's misplacing items, word searching, having trouble using a map, they joke with their friends about their memory loss. You're feeling that that is mild cognitive impairment versus just normal aging changes in memory. So we will find out the answers to these as we go through the lecture today. All right, I am going to share my screen. Can you see my lecture notes?
Yes.
Yes, okay, all right. I'd like for this to be somewhat of an interactive lecture. Many of you may work in healthcare setting and have experiences with working with patients with either delirium or dementia. So I would be most grateful if you would share maybe some communication techniques that you have found helpful or safety precautions that you maybe have put in place. So please feel free to jump in. I can't see hands waved or anything, but just speak up and jump in and if you'd like to contribute anything. All right, so like I mentioned, we're talking about delirium and the dementias and some amnestic disorders, and this is chapter 38 of Boyd. So what is a neurocognitive disorder? These disorders, it's a term that's used to describe cognitive functioning that's closely linked to specific areas of the brain. And these areas correlate with either thinking or cognition, with reasoning, with memory, with learning, and with speaking. So when there's dysfunction related to these, if these disorders are showing presentation in your patients, that's where we're going to see the changes. With thinking, with reasoning, with memory, the ability to learn new things or recall things they've learned in the past, and with their speech. So there can be significant deficits in cognition and memory that reflect a significant change from a previous level of functioning. So these disorders can be very difficult for the patient and for the family. So we can see some major changes related to this. So they're also defined as minor and major. So what makes them minor, what makes them major? It really has to do with the severity of the symptoms. Okay, so somebody with moderate to severe later stages of dementia, it's considered a major dementia. Okay, so we know on the CDC reports that people are living longer, right? Especially with the advances in technology and diagnostics, people are living much longer. In fact, they've seen improvements over the last decade of greater than 35% longer than normally. So we know that as people age, they have increased potential for disease. So we do see patients with comorbidities. And unfortunately, especially with dementia, sometimes you see people who have escaped these comorbidities, who fled fairly healthy lifestyles, but then they get dementia. And it hugely affects their ability to function and their quality of life, as well as their families. So this lecture is going to focus on both acute and chronic confusion, and we'll especially focus on the elderly. We'll be looking at how to accurately assess and document what we see in people who are confused. It can be very difficult to document patients who are showing either acute or chronic confusion. So how do we do that? What's important to document? We'll look at nursing interventions, including how best to communicate with the confused patient, what we can learn from working with confused patients, and then how we can help families and caregivers for these patients. What we do know is with confusion, whether acute or chronic, that it can mask significant medical diagnoses, and it almost always complicates the course of treatment and recovery. So confusion can just make it more difficult to figure out when something else is going on with the patient. So it just adds another layer that we have to work through and differentially diagnose so that we can make sure we're looking at the cause of the confusion. All right. Like I mentioned, acute confusion, the medical term for acute confusion is delirium. So if you see the word delirious or delirium, all that means is somebody is acutely confused, okay? Chronic confusion, like I said, is categorized as to minor, and that can be most often mild cognitive impairment, and with major being dementias. There are several types of dementias. Alzheimer's is just one of the many types of dementia. We'll talk about that in a little more depth. These confusion is always described by its clinical features with regard to certain things. The onset, was it sudden? Did it occur slowly over time? The course also relates to how it occurs over time. Progression as well. The duration, did it last a couple days, a week, a month? Are we looking at years? Okay. The degree of awareness of the patient. Okay. Is the patient's level of consciousness affected by the delirium or the dementia? Okay. So for our delirium patients, somebody with an acute confusion, they may be very somnolent, right? Their level of consciousness is greatly affected, possibly. For those with dementia, they're awake, they're alert, but they're confused. They have this chronic confusion. Okay, so the level of awareness of the patient. As the patient progresses with dementia, they become less interactive, and they can progress to a comatose state. So in those senses, yes, awareness is definitely affected, and alertness, okay? All right, other things we look at when we compare diagnostic criteria for minor and major neurocognitive disorders, we look at modest or mild to significant major cognitive decline in one or more cognitive domains. So when we talk about cognitive domains, we're looking at things like complex attention. They're able to focus and complete tasks. Executive function. They start something that takes a thought process to complete it. They go through that thought process and complete the task. Learning. Can they learn something new? Okay. There is something that goes to that saying is you can't teach an old dog new tricks. And that's part of normal aging. We lose neuron synapses as we age, but then there's something that becomes dysfunctional, okay? Levels of that become dysfunctional. Language, perceptual motor, and social cognition. We see behavioral changes with these disorders. People who may have been very outgoing may become withdrawn and more introverted. People who may have been very introverted during their life now become socially inappropriate. So this is really, really difficult for families to see and to experience this. Patients who may have never sworn their whole life now swear like a sailor, right? And it's all part of the disease process. Families need to know that. And then, of course, healthcare workers need to reinforce this to families that we understand that this is part of the disease. Okay. Somebody might be sexually inappropriate. Patients might grab staff, right? So this might be something that's completely completely changed from their normal, right? So it like I said, it can be really, really difficult for families. We also think of these disorders, just like we think of other disorders, as primary or secondary, right? So if it's primary, we're talking disease within the brain itself. We call it organic brain disease. And secondary would be caused from another disorder, right? That leads to a dementia. For example, somebody with Parkinson's disease, right? Somebody that has boxer's dementia. They've been NFL football their whole life, and now they've retired, and they're showing signs of dementia from repeated brain injury, that coup contra coup, where they get contusions to their brain repeatedly. Boxers is another example of that. Other disorders that can cause dementias include HIV, tuberculosis. So there are several other disorders that can be secondary causes of dementias. So most likely you're going to be coming in contact with patients if you are working in any setting. You can have a delirious patient. If you're working more so with the elderly, you may come in contact with patients with dementias. We do know that there is a form of early onset dementia that is strongly linked to genetics. Okay, so that would be the answer to that one poll question with early onset dementia. The best answer for the causes of dementia for that question were those genetics. The other ones had little issues in them that we'll clarify over the course of the lecture. Something else that's important to know between confusion and between acute and chronic confusion, or delirium and dementia, is that delirium always has a cause. Okay? There's always something that's causing it, and we have to figure out what that is. With dementia, the causes, there are several theories, but it's still thought to be not sure. And what they think is that it is multifactorial. Okay, so there are environmental issues, there are genetic issues, there are organic issues. There's several different theories, 3 major theories for dementia, but it is not curative, and these patients go on to die from dementia. And the course of disease is typically over a bit over a decade. Okay. All right, so we're going to talk first about delirium. Okay, so I mentioned that there's always a cause, so we got to rule things out and figure out the cause. It most often has a sudden onset, but there can be like some prodromal symptoms that occur prior that can give you an idea that a patient might be becoming acutely confused. So there might be little things, but most often it's like kind of happens pretty quickly, pretty suddenly. So it's characterized by a disturbance in attention and awareness and a change in cognition that develops really quickly over a short period. Examples of when you might have those prodromal symptoms might be if there's like a metabolic disorder or electrolyte imbalance or some type of systemic illness. So it is temporary. It's reversible. Like I said, there's always a cause, and it's characterized by several of these characteristics, such as patient may not be able to focus, have decreased attentiveness, be distracted, may not be able to sleep well, they're very restless, they might be hyperactive, or they could be just vegetative, and where they're in a catatonic stupor. They may have a tremor. They may present with emotional instability and have components of fear or anxiety or depression, irritability or anger, euphoria or apathy. They may be calling out for help, cursing, muttering, moaning. They're at risk for elopement from your ER. So the patient, or from your floor, the patient who is acutely confused can present across this whole continuum. So think of it as mild to severe, right? So just like with dementia, we have stages. With delirium, we also have, somebody who's mildly confused. We say they're pleasantly confused. They might just, have not be disoriented, and they, might have some, some acute confusion. So, so we have to assess our patient, and how do we document that? So we have to describe their behaviors, right? So that's what we do in our note. We describe the behaviors, and in report, you want to describe your behaviors. I think that's so important, because of the fact that you can have somebody that's very, very mildly confused to somebody who's like a risk to them to harm themselves, right? So always describe your behaviors. And if somebody tells you in report the patient's confused, you do hear this all the time, and they don't describe the behaviors, you have no idea what you're walking into. So always describe the behaviors, okay? So the patient might be having hallucinations. That's another thing that can be common with somebody with delirium. It could be substance related. It may not be. They may be delusional. Okay, they might think that they're president, or that they might have paranoia that somebody's out to get them. That they might have delusions of grandeur, that they're coming to save the world, or they have to, whatever it may be. I've heard so many different stories with delusion. Fluctuating cycle, motor activity, emotional instability, and then physical symptoms and awareness states. So all dependent on the degree, from mild to severe. So DSM, your DSM, which I'm sure you're learning about in your psych lectures with Professor Van Cott, it's a really good source for early identification and diagnosis for delirium. It occurs pretty often, and 6 to 30% of hospitalized patients, over half of post-surgical patients have some form of delirium. And that's often related to anesthesia, medications they're receiving, possibly analgesics. So there are different things that can cause post-surgical delirium. And 16% of the elderly can have delirium. In long-term care facilities, delirium can be present, and it's difficult often, especially if the patient has dementia already. You can have a delirium on top of a dementia, right? And we see this in the ER all the time. We have a patient come in by EMS from a long-term care facility. They have a history of, let's say they're in the moderate to severe stages of dementia, and they've had what we call a change in LOC, right? So their baseline level of confusion has worsened, or now they're agitated, and or now they can't keep them from wandering into patients' rooms and taking things from patients, or they're more agitated. They're acting out against staff or other people in the nursing home. So this is a change, and most likely it's either progression of the dementia, but even more so likely there's a delirium on top of the dementia. So what do? We start ruling things out, right? So we want to get a urine sample first thing, right? And we want to check that urine for leukocytes and make sure they don't have a UTI. And oftentimes that is the cause, or some other form of infection. Maybe they have a cellulitis, or maybe they have, maybe their sugars are really, really high. They're also diabetic, and they've got acute confusion related to hyperglycemia, okay? Delirium is the most common complication of hospitalization among people over 65. Another place that commonly is prone to delirium is the ICU setting, okay? They say that, I'll move this out of the way. They say that almost 80% of those treated in ICUs develop delirium. When it's not recognized, it can affect a patient's outcomes, right? It can hinder their recovery. And if it's prolonged, it's associated with poor long-term outcomes, both mental and physical, for the patient. So you hear about patients who are in ICU for long periods of time, they develop depression, or they might become so depressed that they become suicidal, or they have physical poor outcomes, and they hold a higher mortality rate. So it's really important that we assess for delirium every day in our patients in the ICU setting. Okay, so all of our patients who are at risk, but especially in the ICU setting. So if you think about the ICU setting, what do you think it is about the ICU setting that would increase somebody's risk for acute confusion?
The background noises.
Yeah, all those beeps, and all those beeps keep you awake, and you don't get good sleep. What else? That's good, Reggie.
Medication.
Yeah, so these patients probably of course, if they're in the ICU, they're pretty sick to begin with, right? So medications related to, to their diagnosis, so whether it's an antibiotic or, a pain medication. If you look in your drug book and you just flip through the pages and randomly pick medications, I've done this before, and just see what the most common side effects are of medications, along with nausea, is confusion. Right? So many medications can cause confusion. And then some medications are known to, if used in longer term, there's a specific class of drug that can cause a psychosis in patients. Do you remember we talked about it in endocrine? Steroids, right? So there's that steroid psychosis, where a patient, maybe they come in and they get intubated because they've had a severe asthmatic attack, and now they have delirium and they're psychotic. They're hallucinating, they're reaching out, they're pulling out tubes. It's called the steroid psychosis, okay? We wean them down off the steroid nice and slowly, so they're Adrenal gland can build back up. It's normal. Endogenous glucocorticoid production, and we safely get them off the steroid, and we see a change back to their normal baseline, okay? So with delirium, I just mentioned the word baseline, and that's so important because your assessment begins with evaluation of a patient's baseline, or finding out what was the patient's baseline. So when I get report from that paramedic, I want to know, okay, what's this patient's baseline? Or do they have dementia? Are they alert and oriented ×3 and they're just in short-term rehab for a total knee rehab? What is their baseline? If I can't get it from the paramedic, I am looking for notes in the documentation that came with the patient, or I'm also calling the family and finding out what is this patient's baseline. Because if I don't have the baseline, I'm kind of lost. I don't know what is their normal, okay? So always the assessment for delirium or dementia is knowing what is the patient's baseline. So if you're not told that, you are asking that, right? That's should pop into your head during your report, is to find out what the patient's baseline is. Okay. So Harvard Med School did an ICU study, and they were able to decrease delirium in the ICU from 26% to 8%. Okay. And they helped prevent mental status declination in these patients during hospitalization. How did they do that? So they did these several interventions, and they created an assessment tool for delirium screening, and it's recommended by the American College of Critical Care Medicine. And they did for any elders that came in the hospital and then that may have ended up in ICU, they started with a screening at admission, and then they did it throughout the patient's hospital stay. So they screened for delirium, okay? And they assessed any cognitive impairment, okay? They looked at sleep deprivation, if the patient was immobile, their hydration status, if they were visually or hearing impaired. And what they did is they involved family with stimulating the patient. So right now, unfortunately, we can't do that because family can't come into the hospital, but they would have family every day, read to the patient, touch the patient, comb their hair, stimulate the patient, so talk to the patient. Nurses can do that as well, right? We can stimulate the patient, but when it's family, it's ideal, right? We would give memory cues. So they would tell them, you know, you were born in the spring. What month were you born in? Or what holiday just happened? It's right after Christmas. So they would give them memory cues. They would make sure they put their glasses on them and their hearing aids in, right? This is huge. In fact, they're saying people who have impaired hearing are at increased risk for dementia. I don't know if you've heard that recently. I've heard that over the last couple of years. Those who have chronic hearing loss are at an increased risk of dementia. Okay. Increase their activity. Okay, so range of motion, getting them up into the chair, repositioning them every 2 hours minimally. They allowed exposure to natural light. Okay, we know there's a lot of rooms in ICUs that are internal and do not have windows. In this picture here, the blinds are closed, right? So in the daytime, these blinds should be wide open and natural light should come into the room. In our psych area in the ER where I work, there's no windows, and there's patients that stay there for sometimes a month or more. And we do not, I don't know how we can expect them to not have delirium or to get agitated, right? They need sunlight, okay? They limit benzodiazepines. So, you know, before, you know, the first sign a patient's getting agitated, we slap them with some Haldol or lorazepam. We give them something that, because we don't want it to progress. But what's important is that if we're doing all of these other, addressing all of these other things, we want to limit, to use it sparingly when it's absolutely necessary. If a patient's on a ventilator, if they're on assist control, that ventilator is supporting, it's making sure the patient's getting that 12 breaths per minute, 14 breaths per minute, whatever is indicated for the patient. They put them on SIMV and they allow the patient to take their own breaths, okay? And so depending on the mode that you have your ventilator on, it makes the patient work harder to breathe. And if they can tolerate that, you let the patient take their own breaths while they're being ventilated, okay? Not assist control. So they were able to decrease delirium from 26 to 8%. So that's much, much improved. So, and these are things that we can learn from, right? Even if we're not working in the ICU, right? So open your blinds, let natural light come in, touch your patient, talk to your patient, stimulate your patient, get them up and moving, okay? Keep them hydrated. So all of those little things that we do can help decrease delirium, okay? So there's always a cause of delirium. Things that we look at their nutritional status, their fluid status and electrolyte imbalance, any medication reactions or interactions. So maybe it's a combination of two meds together that can cause confusion. Are they diabetic? Are they hypoglycemic? How's their thyroid function, right? So a patient with hyperthyroidism can present with a state of mania, right? So instead of thinking that, this patient's got manic depression and they're in a state of manic state, we're looking at the thyroid function, trying to figure out, what would we expect for this patient in terms of their labs? What would you look for in somebody who's manic due to thyroid disease? What would the TSH be? Would it be high or would it be low? Think about.
I think it would be high.
So the TSH,
Low, because it's the negative feedback.
Yeah.
So our thyroid hormones, Isabella, the T3, T4 would be
Those are
elevated. Those are your
yeah.
hormones that are causing the manic state. And so what is the hypothalamus doing? It's suppressing its hormone release to the anterior pituitary, and the anterior pituitary isn't kicking out TSH. So your TSH is going to be low. So the TSH will be high when the thyroid hormones are low, right? So think again about that heater in your house and how it kicks on when things are high or low. Okay, good. So it's always good to keep reviewing all that stuff. Pituitary disorders, right? So cardiovascular disorders. So when we aren't getting good oxygen to our brain, right? If there's some type of hypoxic event, a patient can become disoriented. Infection, we know that. Urinary alterations, hypothermia, hyperthermia. B12, or thiamine deficiency, is known to cause acute confusion. Okay, so we can give thiamine IV. In fact, we do banana bags in our patients with that are malnourished, most often due to alcohol abuse or substance abuse. We will often give thiamine. It's part of the CWA protocol. Medication induced. So there are many, I mentioned steroids, tricyclic antidepressants, narcotics, digoxin, beta blockers, NSAIDs, corticosteroids, antibiotics. All of these can cause delirium. Anticholinergics can cause both acute and chronic confusion. So how do we rule out if it's medication induced? We do something like in the outpatient setting, we do the brown bag test, or a patient might bring a bag of all their medications, right? And they dump out like 50 medications onto your counter, and you have to record all these medications and look at, so what could be interacting, what could possibly be causing this acute confusion, this change in this patient's status, okay? pharmacy is invaluable in determining this, right? Inflammation. So some type of inflammatory disorder or toxic substance can interfere with brain function. It disturbs neurotransmitters that communicate between nerve cells. So that's always a possibility. So what are anticholinergic meds that can affect? Anticholinergic meds reduce the effects of something called acetylcholine in the brain. And our elderly have less acetylcholine than young people. And when you have less acetylcholine, you're at increased risk for delirium, okay? And it's one of the hypothetical causes of dementia, okay? And so there's less acetylcholine available. We'll talk about dementia and how CAT, which was in that question, we'll talk some more about that when we talk about dementia. Make sure you understand that. So medications that are anticholinergics include like nifedipine, Procardia, that's a trade name for that, Adalat, Detrol, which is a med for incontinence. These can all trigger delirium as a side effect. All right, symptoms can be vague, right? Especially in the elderly, the subtle confusion, the subtle change in their mental status. So those who know the patient well can identify it. Something's going on with my mom, you know, my dad, something's off. So they are showing these signs of delirium. All right, so we look at labs, we look at urine, we can do a chest x-ray. Is there a pneumonia? Sometimes a head CT, right? Maybe a patient has a brain tumor, okay? Maybe the patient's showing signs of dementia, some cerebral atrophy. We do a neuro assessment and psychiatric consult. If nothing's found, they pull in psych team and they evaluate the patient for more organic issues. Is the patient bipolar? Is the patient schizophrenic? Is the patient having severe depression or euphoria? Okay, so a psych consult's brought in if the reason is not identified. Okay, there are no drugs specifically that treat delirium. The fewer the meds, the better, right? So the more meds the patient's receiving, it can worsen the situation. So we need to find the cause and treat the cause. If the patient's at risk for hurting themselves with delirium, you're obviously gonna treat them. So it could be, you know, it could be an antipsychotic, or it could be, but most often we try to steer away from those things unless they're at harm for themselves. All right, so your documentation, it should include how you became aware of the behavior, okay? Patient calling out, entered room, and then what did you see is what you would describe. You would include your vital signs, any results of a neuro and any focus assessments that are important. Patient voided, urine's cloudy, foul smelling, okay. MD made aware, urine culture set, UA and CNS set. Think about the contributing factors. So patient with reports no sleep last night. Patient received 6 a.m. dose of IV Dilaudid. Patient's wound oozing green purulent drainage. Patient disappears into the bathroom and comes out impaired. What did you see? Okay, describe the behaviors. Patient had a recent visit from a questionable visitor, right? That happens. So you want to describe. You're not going to accuse, like you're not, if you didn't see it, you can't say what you didn't see, but you can describe what happened, right? So, And then obviously you're checking your lab results. And then interventions. Whenever you see an abnormal, you always document an intervention. What did you do to keep that patient safe? Okay. So for example, here's a note. 2/10/2020 at 8:20. Patient observed reaching into the air as if attempting to grab something. Patient asked about patient behavior. Patient had word salad. Dream, job, dog, gone. So in quotes, what the patient said, if at all possible. Swears, whatever you see swears in the ED record all the time, in quotes from the patient, how, agitated or disoriented the patient is. The vital signs were stable, so VSS, neuroassessment, otherwise within normal, reported change in cognition to healthcare provider, named the doctor, Dr. Smith at 08:25. And then put a note, aware of recent 06 administration of Salumedrol IV. So it's not saying that's the reason, but the nurse is aware of that as a potential cause. Order received to hold the next dose. Stat labs, patient placed on 1-to-1 for safety. We'll continue to monitor the patient closely. Okay, and then you follow that up with another note within the hour. Okay, so patient, that observer's in place all the time. So in each of your notes, I end my notes in the constant observation continues or remains in place. So the safety is really, really important for these patients. 2/10/2020, 08:40, Dr. Smith at bedside, labs drawn, 1-to-1 observation continues. We'll continue to monitor for LOC changes and safety. Okay, so that would be an example of a documentation. So describe the behavior. Don't just say patient's confused. And you see that all the time. Describe the behavior. So it's clear when whoever's reading that note, they understand exactly what they're walking into or what and they have something to compare it to. Okay. So I would like to see you guys in report, when you're getting a report and they say your patient's confused, I want you to ask them to clarify that, to give you a little more information. Is it mild, moderate, severe? What did you see? Okay, we're going to go on to talk about dementias. Okay, so what are dementias? Dementias are a syndrome of acquired, persistent. So it's not something that starts and then goes away. It's chronic, right? It's persistent and it's progressively worsening. Okay, mental impairment without impaired consciousness. So when the patient's alert, they're having an impairment. Okay, caused by progressive neurodegenerative disease. It's characterized by deficits initially in memory. Okay, that's important to know. It starts off with memory issues, difficulty remembering things that normally they would remember. And eventually it progresses to language, which is called aphasia. So you should know the medical terminology on the board. You may not, it might just be the term, and you have to know the definition. So make sure you know what each of these means. Visual perception, so they have trouble with their perception and what they see. So they might reach out for something that they see that's farther away than right in front of them. And that's termed agnosia, agnosia. The ability to organize thoughts and take action. So they have to think and then follow through and complete an action. That's called executive function. And they execute a task and complete it. And then the ability to act out intentionally, that's also called apraxia. Okay. Course on average is 10 years from the beginning of symptom expression to death. But with dementia, we do know that there are symptoms that might show even decades earlier for possible signs of dementia. And then primary, we know that's a sign of organic brain disease, such as Alzheimer's, Lewy body, frontotemporal lobar. So the disorders occurring within the brain itself. So it's primary. Okay. secondary traumatic brain injury, advanced alcoholism. We know about Wernicke's encephalopathy as a cause of substance abuse, infection that's affected the brain. There's all types of different diseases, and they're listed on page 720. They start on 727 and go through 729 in your book. Please read those. I'm not going to go over each of them individually, but make sure that you know, especially with Lewy body. I've seen a lot of Lewy body dementia in the ED, and it's characterized by visual hallucinations. That's important to remember, and has more REM sleep disorder characteristics and spontaneous Parkinsonism characteristics with these Lewy bodies. So these Lewy bodies are found in the cortical location in the brain, which are thought to be responsible for the disorder. And it carries about a 5 to 7 year survival rate. So I've seen this past year quite a bit in the ED. There are over 5 million Americans living with Alzheimer's dementia. It's the 6th leading cause of death in the US and the 5th in those greater than 65 years of age. Alzheimer's dementia has a significant impact on the patient and on caregivers and on the economy of the country. In 2017, AD cost the nation $259 billion, and Medicare and Medicaid covered 67% of that $259 billion, 56 billion out-of-pocket expenses. And we know that caregivers who are taking care of patients with dementia in their home have saved the country just 230 billion caregiver value add. So unfortunately, caregivers have physical and mental repercussions when they care for patients with dementia. So just a little bit about caregivers. Approximately 2/3 of caregivers are women, and 34% approximately are over age 65. So these are older people as well who may have their own healthcare needs. 41% of caregivers have a household income of under 50,000 or less. Most often they're caring for their parents, so their parents with dementia. And it is estimated that 250,000 children and young adults between ages 8 and 18 provide help to somebody with Alzheimer's disease or other types of dementia. So it affects families, right? And we find that those who are caretakers suffer more from things like depression, okay? So unfortunately, it can take a toll. The majority live in homes where family and friends provide most of their care. So there's a high burden of suffering for patients, for their families, and for society. And often it can complicate other disease processes. There's increased anxiety, and depression affects approximately 20% of those with dementia. So especially early on, in the moderate to later stages, they become less depressed because they're not really aware. In the earlier stages, patients are aware of what's to come for them, and they often will have depression. With caregivers, over half of those caregivers have some forms of depression themselves. So as nurses, we find ourselves not just caring for the patient, but for their families as well, right? So it's really important that we're aware of that, and that we offer support, that we're empathic, that we understand the needs of the caretakers. Sometimes I'll get report and I'll hear a nurse say and report, that the family doesn't call, they don't come by, they just dump their patient off at the door. And I think about that, and it's like, that's judgmental, isn't it? Right? These these caregivers may have very little respite, meaning they don't get much assistance. They don't get many breaks from caring for their family members. Patients with dementia have sleep issues. They're up in the middle of the night. They worry about their family wandering. So all of these things are important to be aware of, and not to judge family members who they might take a respite when their patient comes in, when their family member comes in the hospital, right? Long-term care facilities, they have dementia units, so secure, safe units for patients. Let's talk about the causes of dementia. So there is no definitive cause, so there are many theories, and it's overall thought to be multifactorial. So a lot of different things can affect it. So it cannot totally be explained by genetics, although there are several genes that are associated with Alzheimer's dementia. Chromosome 21, those who have Down syndrome, and I was looking at this in your book, it does talk about that more than previous editions. The link for those with Down syndrome that live to be over 40, the majority have dementia. There's something about that chromosome 21 and its effects on something called ApoE that can increase the risk of dementia. The most common gene associated with late onset Alzheimer's disease is a risk gene, so it increases risk, called apolipoprotein E4 or ApoE. It's not always present, so they don't recommend genetic testing for late late onset dementia, right? So there's no really strong correlation for late onset dementia. So they might, if you've got dementia in your family and it's late onset, they most often are not going to recommend you go for genetic testing. With early onset, there's a much stronger link with genetics. Okay, so these are patients who have onset of dementia between 30 and under 60 years of age. So there are 3 mutant genes that have been linked to early onset Alzheimer's, and they include amyloid precursor protein, or APP, presenilin 1 and presenilin 2. You don't have to know those. I just want you to know that there are definitely mutant genes that are linked to early onset Alzheimer's, and they can be tested for. So they can provide more certain results if a patient's showing early symptoms, or if there's a family history within your family. And they do recommend it, and it can be helpful. Also in terms of drug trials and research that's going on right now. There's a really good movie out about early onset dementia. Has anybody seen Still Alice? The movie Still Alice? It's a really good movie.
Yeah, it's a good one. Yeah.
The author's from this area. She's from the Cape, Chatham area.
There is actually a lady I used to take care of when I was a CNA. She's with a Huntington's disease, and there was the same lady who wrote the book Still Alice was going to interview her and do a book for her, because it's very rare for someone with Huntington disease to be cared at home. And as you were talking about the caregivers, how they get, it's how hard it is for them to take care of people with those diseases. Her husband, I don't even know if she's still alive, to be honest with you. He used to do so much for her, and every time we'll go in the home and he was like, I need some time just for myself, like an hour, just to get out of the house, you know. So hard.
Yeah, it is really, really difficult. And we have to remember that when we talk to these family members. And I know they are offering now paying caregivers because it saves so much money than to put pay, as long as they're safe in the home. I have seen like young people actually get paid to stay home and care for their family member. So that is possibility that is helpful in terms of because there is a lot of loss of income for people who are home caring for family members. All right, so other causes. So head trauma is the greatest risk if other risk factors are present. I had a patient in the ED who was in for over a month, possibly 2 months, who'd had a total brain injury, had had a bike accident, also alcohol, chronic alcohol use with dementia related to that. So those causes combined together increases patients' risk for dementia. All right, so let's talk about these 3 theories, okay? There's the acetylcholine theory, there's the glutamate theory, and there's the plaques and tangles theory, okay? The plaques and tangles is most highly related to early onset dementia, okay? Let's talk about acetylcholine. So there is a biochemical abnormality associated with Alzheimer's dementia that was first discovered in 1976. There is an enzyme called choline acetyltransferase, or CAT, okay? And that is an enzyme. And they found when they did autopsies and looked at the brains of those with these dementia state, that they had a 90% reduction of this enzyme, CAT, in the hippocampus and in the cerebral cortex, okay? So this enzyme, choline acetyltransferase, it's not elevated, like the question said in the pretest, it's actually reduced, okay? So there's the enzyme choline acetyltransferase, CAT, was reduced by 90% in the hippocampus and the cerebral cortex. This enzyme is required to produce acetylcholine. And then we know that as we get older, there's less acetylcholine produced anyway, so we're at increased risk. So it's like a double whammy, so as we age. So if there's a reduction of this enzyme, it leads to a reduction also in acetylcholine. And acetylcholine is responsible for functioning of the hippocampus. It's our major contributor to memory. It's also seen, there's also deficiencies in norepinephrine and serotonin and somatostatin. And those deficiencies are responsible for some of the behavioral changes we see with dementia. And so many of the meds that we give work on these areas, okay? So they work to help improve symptoms related to these deficiencies. That's acetylcholine. So now glutamate, okay? There's another biochemical abnormality, and it's excessive glutamate. Glutamate's an amino acid or a protein, and it leads to the overstimulation of something called NMDA receptors, okay? N-methyl D aspartate, or NMDA. Receptors, and that leads to increased intracellular calcium and subsequent degeneration and death of neurons. So too much calcium causes degeneration and affects neurons. It kills neurons, okay? So that's how glutamate works. So it's an amino acid. Lastly is the plaques and tangles theory. They found that these patients have a high number of plaques and tangles, okay? Plaques lie in spaces between neurons in the brain, and neurofibrillary tangles clump together inside the neurons, and they cause the brain cells to twist up and die. So they twist up together. There's a video right here. This is a new link. Every year these links change. I don't know why they can't like stay the same, but I found the link that has this video. I'm going to have you watch that either in clinical If you could ask your clinical instructor, I'll give these links to them. So watch it when this is on tomorrow in clinical, we're really going to be focusing on confusion. Okay, so your case studies and things all relate to patients with dementia. So we'll have time there to watch some of these videos. So these plaques and tangles, they block the transmission of electrical signals that assist with thinking, memory, talking, and movement. And as AD progresses and nerve cells die, the brain shrinks. And this is what we see on CAT scan. And I always look for this when I have a patient that's had a head CT who I'm questioning, you know, dementia. Maybe it hasn't been diagnosed yet, or they're looking for progression of disease. Has the cerebrum shrunk? Okay, the sulci are widened and the brain shrinks. You have brain atrophy. So, and as that worsens, we see functional abilities deteriorating. These plaques, they're dense, sticky substance, and they're made up of the accumulation of a protein called beta amyloid. You might hear that. So plaques are made up of sticky beta amyloid, and the tangles are twisted fibers caused by changes in a protein called tau. Okay, so tau relates to the tangles, and the beta amyloid relates to the plaques. So these plaques lie in between the spaces between the billions of nerve cells, and they cause brain cells to twist up and die. So here's an example of a PET scan that shows a normal brain and then a patient with Alzheimer's disease. So we look at CTs, we look at ApoE, we look for clinical symptoms, we look at the CT, and they say that Alzheimer's dementia can be diagnosed with 90% accuracy by experienced clinicians, even in the office, right? So we see changes, and you always hear of, you know, there's an assessment where you have patient draw a clock, right? And they put the hands on the clock for 3 p.m. or 3:10 p.m. and the patient's clock is way off. Or it might be, you know, the hands might be outside the actual circle of the clock. All right, so we're going to go on to talk now about what's really interesting is,
Professor?
yes.
I have a question about what you are talking right now. I remember in prep you they talked about the oxidative stress. So do you want us to also know about that?
Yeah, so there's
And also,
other theories, right? Inflammation. We know inflammation's like a big issue. Anything that causes decreased oxygen to the brain, vascular disease, right? If somebody has cardiovascular disease, they might have carotid disease. They might have microvascular ischemia to their brain. Anything that's going to decrease oxygen supply to the brain is another cause. Okay, so there are definitely other causes. The three I talked about are the main theories for dementia, but we do know that there are several. So that's good. I'm glad you brought that up. So you'll read about that in your book.
okay.
Page 712.
Do you want us to know the difference between mild, moderate, and severe?
Yeah, we're about to talk about that, and you will be asked to kind of differentiate, and also differentiate between normal aging, what we call mild cognitive impairment, and onset of dementia. Okay, so I mentioned that it's a gradual process. And it's multifactorial, so it's a combination of biological, genetic, environmental, lifestyle factors. Can they hear? Do they have hearing loss? What type of diet have they eaten? They have found that patients who eat a Mediterranean diet, so the same diets that are healthy for hypertension prevention, for heart disease prevention, is also good for your brain, okay? So that Mediterranean diet. getting rid of chemicals in your diet, things that cause inflammation, things we eat, anything that is chemically laden, has preservatives. So fresh, whole foods, raw foods, those are all healthy for your body, okay? And can prevent just disease in general, okay? All right, so and then just knowing too that there is that genetic link, especially with early onset. So with Alzheimer's dementia, there's a preclinical phase that lasts up to 20 years prior to symptom expression. So if you start having symptoms at age, let's say 60, about 20 years before that, in your 40s, you might start seeing some changes, okay? But also as we age, we lose neurons, right? So it's how do we determine, how do we see people who are at risk? So we're often like kind of distinguishing between memory loss due to normal aging, memory loss due to Alzheimer's. It can be challenging. So with normal aging, we do see a decrease in the number of cells or neurons, just like we have decreased kidney function and all the other organs start going downhill, right? So this makes it harder for patients, for people, just the general population as they age, to learn new things or remember familiar words. And that's why I mentioned, that truth to the statement, you can't teach an old dog new tricks. So we might find some people normally aging, we have difficulty coming up with names of acquaintances. We see somebody and we can't think of their name. We have to word search for a word. It may take me a second to recall the word, but then it comes to me. We might have trouble remembering where we left our glasses or where we left our keys, where we parked our car. And normal people, what do? We try to create things, cues for ourselves. We always hang our keys on the hook as we walk in the door. We park in the same spot in the parking lot every day. So those of us with normal aging, we start doing stuff like that, right? So you'll see me out in the parking lot trying to find my car after clinical. If I parked not in the place I usually park, because I'm so used to parking, I'm sometimes distracted when I'm walking in and I'm not mindful of where I parked sometimes. So I'm like walking around the parking lot looking for my car. The more stress we have, so you guys are under a lot of stress right now, right? You've got a lot going on. And so you might be more forgetful right now while you're in nursing school than if you didn't have your studies to deal with every day. So all of these things can increase. So it's all about mindfulness too, being aware of it and then making sure you're mindful when you're doing things. As we become stressed, those mindfulness kind of goes out the window, right? So we want to always try to stay mindful. Things like meditation can help you stay mindful. Things like yoga, so stress management is really good for you in terms of stress release, so that you can stay functioning cognitively at your best. All right, so that's normal aging. We're going to go to this next slide here. But there's something called mild cognitive impairment that I want to introduce with this slide. So what happens with mild cognitive impairment? So if you watch This Is Us, you know that, I can't think of her name right now, the mom. What's the mom on This Is Us? Jack and what is it?
I think, isn't it played by Mandy Moore? I don't know her name though.
Yeah, so Mandy Moore.
Rebecca.
Rebecca. So Rebecca starts, she starts forgetting things. She gets lost. They notice changes, right? So that she gets evaluated and they diagnose her with mild cognitive impairment. Okay, and that can progress to dementia. Unfortunately, I think that's what happens with her. But you guys just kind of have to watch and wait and see what happens. But what is mild cognitive impairment? Memory problems are greater than those expected for that age. However, There's no personality changes or problems characteristics of dementia. With dementia, we start seeing people not act themselves, okay? Like I said before, they maybe get irritable when they've been really easygoing their whole life, or you know, they might be inappropriate in some ways or another that was never the case, okay? So you see behavioral changes when it becomes Alzheimer's dementia. So MCI is more memory issues. It can progress. There is a certain percent of people that over the next 7 years they found do go on to Alzheimer's, but sometimes they don't. They just go on and they function at that level, maybe a little bit less, and just have normal cognitive age-related changes, okay? So that is MCI. All right, so this slide, you want to look at the slide really well because you're going to be asked on the test to identify behaviors related to these levels, okay? So normal age-related forgetfulness. Sometimes misplaces glasses, keys, or other items, word searching occasionally, may forget momentarily where they are. So I'm out in the, hopefully I'm under normal age-related forgetfulness, out in the parking lot, looking for my car until I remember where it's at. Quickly reorient themselves, and they joke about their memory loss. So if you see them, you know, joking to their friends or family that, you know, they don't know what's going on, but their memory's not as good as it used to be. MCI, frequently misplace items, repeatedly, their phone, and then take away the things like stressors and everything. So this is just more difficulty using the right word, temporarily becoming lost more often, trouble understanding a map. So they're starting to have some visual spatial issues, okay? Worry about memory loss, and others are noticing it. So they're not joking about it, they start worrying about it, okay? So that's MCI, and that can continue, and that can progress to dementia, or it can go on and stay the same there. All right, when things progress to dementia, they forget what an item's for. So they're holding their keys and they can't remember what they're used for, or they have, you know, the wrong key. They're using, you know, something else to get in the house other than their keys, or maybe it's the keys to their car and trying to get into the door. They not just can't think of a word, they start putting the wrong word in there, okay? So they substitute words, or they make up a word. They're easily disoriented or lost in familiar places, their own home. They forget how to get to the bathroom, or they start wandering in their home because they may forget what they intended to do. They might take something and put it where it shouldn't be. Like they might take, you know, their keys and put it, you'll find their keys in the refrigerator or in the freezer or somewhere that it's definitely not supposed to be. And they're no longer worrying about these things, that they have no awareness of these things now. I mean, they're distraught in the moment, but they really, you know, they may not, they start losing, and as it progresses more so, you know, the more severe, they, you'll find that often they make excuses, right? So they might say, you know, they might make an excuse for not remembering that it was their anniversary, or this is another thing with dementia. Something that they like every year they go and they do the same thing every year of their life. They go back and then go with their friends and they travel to Hilton Head and go golfing, ladies' weekend. They completely forget about it. They can't even recall that they even did it. They don't show up for events. They start forgetting names of people close to them, okay? And they are embarrassed in that moment. They start making excuses. But a lot of times this is where it just becomes really, really difficult for family. So they do break stages down. And this is helpful for family, but often you just see mild, moderate, and severe stages, but there are stages within those. What's important about these stages, I'm not going to ask you, is this stage 1, is this stage 2, is this stage 3? And the stages are not absolute. They often run into the other, but how is this helpful? It helps families to see the progression of the disease with their loved one, with their family member. So that's important. Stage 1, no apparent decline in memory, despite changes in the brain. So it's subclinical, okay? Stage 2, forgetfulness, short-term memory loss, patients only aware. Stage 3 is more noticeable, it's interfering with their work. Executive function, so the ability to, maybe they started having problems balancing their checkbook, their checkbook gets all messed up, and you know, it can lead to problems, right? Stage 4, they forget major events, confabulation, so they start making up reasons why, excuses for why they've forgotten things or gotten lost. They lie. You might find a family member that's been never lied, now lying to you. This is very difficult for families. So being aware of these, what to expect, families, and that it's the disease, it's not the patient, right? So it's not their family member, it's the disease taking hold of their brain. They start withdrawing socially. Okay, so they don't want to go out. They don't want to go to the restaurant. They don't want to go to a party. They start withdrawing socially. Okay. Stage 5, moderate cognitive decline. Forget names of close relatives. They start needing assistance with ADLs and maintaining knowledge of self. Stage 6, moderate to severe, unable to manage ADLs. They might have incontinence, sleep disturbance, wandering. Wandering is important. Okay, so wandering greatly ups the ante for family, because now they've got this huge safety issue, even worse than what it's been before. And there are people who wander and die. They are out in the elements. There was a gentleman, I remember maybe 8 to 10 years ago now, the whole Cape, I think, was looking for this gentleman. He drove out of I think Hyannis Toyota parking lot, and he was found days later on the back porch of a home in Eastham in the snow and had passed away. You know, it's so tragic when this happens, and often they are not they're not far from home, you know, but they travel off the beaten path, or they drive somewhere. You see, you know, when there's an alert, a silver alert on the highway when you're driving to look for a car with a license plate from a state. It's when somebody has wandered and they might be driving somewhere. So the police departments and the community should be aware of, if you see somebody who appears to be possibly be wandering and lost, what to do, how to interact. The police are definitely trained to help bring these patients back home safely. There are safe wandering safety programs where patients wear a band. In their clothes, they might have a microchip, or they might have their name on their in their clothes. So if they're found, a family can be notified. So there are some things in place, but unfortunately, bad things happen when patients wander. So families, locks, you know, they put the locks way up high where the patient can't reach, or they make sure the patient's keys are taken away at this point. And this can be really difficult, because now these patients get agitated when they can't get in their car. They don't understand, right? They don't know at this point to protect themselves from the elements. The neurons aren't functioning. They can't say, I'm cold, I'm gonna put a coat on. I'm cold, I'm gonna go inside. They just huddle in the cold and they don't know what to do. So it can be very, very tragic. As nurses, how does this play out in a patient's room? The patient can't tell you that they're cold. They can't tell you they're hungry. They can't tell you they have to go to the bathroom. So what do? They get a little irritable and agitated, or you see a change in their behavior. They start getting fidgety or restless. So what do? We offer them a blanket, or we just give them a blanket. Let's say, let's try going to the bathroom. You haven't been for a while, or you bring them a snack, okay, a healthy snack or something that they enjoy doing. So we address things by looking at their basic needs first, right? And oftentimes, once you do that, they settle down, right? There are times they don't settle down, so we do other things. We're going to spend the last 15 minutes talking about strategies in working with patients with dementia. This just breaks down the mild, moderate, and severe. Moderate, I have a slide on sundowning. In the moderate stages, those middle stages, you can see sundowning. And you can see sundowning in somebody that doesn't have necessarily dementia, but patients who are elderly might have confusion during the evening hours. So there's one, they might have sleep issues and they're up at night and sleeping during the day. This is a long-term care facility that's flip-flopped their wakefulness, and they're all up in the night and sleep in the day. I don't know if that's the best thing to do, but we try to do things that promote health and quality for our patients. So sundowning can be really hard for family. This patient in this article I read talked about, every single day, 5 o'clock, the patient would get restless, and the husband would help the patient into the car every day at 5 o'clock. They would go for a drive, and this would help prevent the confusion and agitation that could ensue if it didn't happen. So we'll talk about something called redirection. Redirection techniques can be very, very helpful. And we'll talk about what not to do in terms of communicating with patients in just a few minutes. These are with severe AD. We have a patient with incontinence. They have swallowing difficulties. They can regress to a fetal state and become comatose and eventually pass away. So they are unable to recognize family, loved ones, or communicate in any meaningful ways with their caregivers or family. Failure to thrive. They might have seizures. They're at risk for infections. So medications. So there is a PDF document in the folder for neurocognitive that really nicely goes over the different medications, okay? I do have a farm calc question on a medication. So you do want to just know the classes of drugs and what they do and what stages they're appropriate for, okay? So for example, there are medications called cholinesterase inhibitors, and these are prescribed for mild to moderate, okay? They prevent the breakdown of acetylcholine, which is important for memory and thinking. So these cholinesterase inhibitors keep acetylcholine from breaking down so there's more available, okay? As we age, we have less acetylcholine, so it's not going to work with more severe forms of dementia. So they're only good for mild to moderate, okay? So with greater stages of dementia, there's less acetylcholine. So it can't prevent the breakdown of something that's not there, right? So the cholinesterase inhibitors, things like Aricept, you see that often, donepezil, Exelon or ristagamine, and Razidine or galantamine. Cognex was the first approved one, or Tacrine, but there's some liver toxicity issues with it. but so you don't see it often prescribed. We see Aricept a lot, right? So that's working for people in mild to moderate stages where they still have some acetylcholine available, okay? So for moderate to severe, we have Namenda. So when I see a patient on memantine or Namenda, I know that they're in the later stages. So if you're not told in report your patient's got, moderate to severe dementia, you see they're on Namenda, you're going to assume it's more later stages, okay? Main effect, it regulates glutamate. So we're looking at that second cause. We talked about that amino acid glutamate. It helps regulate it. It's that's a neurotransmitter involved in memory function. And this is an excess of glutamate can lead to brain cell death. So it delays progression of some symptoms of moderate to severe AD. So this might help keep somebody, more functional in those moderate to severe stages for a longer period of time. So maybe they're able to help dress themselves. If you lay their clothes out in the order that it needs to be put on, they're more likely to be able to stay functioning with their ADLs for a little bit longer when they're taking Namenda. There are some combination meds that combine donepezil with Namenda. For example, Namzaric is a combination medication. We talked about those with antihypertensives. So there's only one pill, you get two nice effects, and that's good. Okay. Just going to talk briefly about amnestic disorders. These are fairly rare. We see these in the ED. A patient who has some type of traumatic event or for some unknown reason, they lose their memory, okay? There are different types of amnestic disorders, but the pathology relates to a loss of memory. A phenomenon in which an experience becomes inaccessible to conscious recall. I had a patient once on the way to he was showering, getting ready to go to his brother's funeral. His brother had died. That was a traumatic event for him. And he came out of the shower and had no recall that his brother had died. He couldn't remember where he was. He had no recall of the event. It can be organic, something occurring within the brain, maybe a tumor. Okay, so a CAT scan is warranted. It could be emotional, dissociative of a mixed origin. It can be permanent, so it may never return, or it could be, time limited. So eventually the memory comes back, okay? There's something called dissociative amnesia. It's an ability to recall important personal information, usually of a stressful or traumatic nature. So it could be a period where the patient was physically abused, or a period when that prisoner of war can't recall what happened to him. Okay, so they disassociate from the event. So extensive to be explained as normal forgetfulness, and it's not substance induced. So they didn't take, some hallucinogen and forget all this stuff. So there's no substances involved, and it's not a result of a neurologic or other medical condition. Localized, inability to recall incidents related to a specific event. Selective, they can recall only certain characteristics, but not everything about an event. They remember getting kidnapped and put into a car, but then from there to the time they were rescued, they can't remember anything. Okay, so it's selective. And then there's generalized, which they cannot recall any detail regarding self-identity or their total life history, who they are, their life history. I think of that movie with Drew Barrymore, right? What's it called? Can't remember.
51st Dates.
51st Dates. So that was a generalized. So every morning she'd have generalized amnestic disorder where she could not recall who she was or her total life history. Okay. All right. So
Wait, sorry. Quick question. So the generalized, do they just forget from like that day on, like in the movie, or is it like their whole past?
I think it can vary. I think
Oh,
it can vary.
Okay.
Sometimes it can be if a patient is feeling really guilty about something, let's say they've had a marital affair, okay, and they're feeling subconsciously very guilty about that. That can precipitate. I remember reading about that. That can precipitate an event where they cannot recall certain things. All right. So there are times that it can, so not dissociative, but there are times where there can be predisposing factors where it is substance induced, okay? So we have patients in the ED who are brought in by EMS and they're found on somebody's doorstep. The patient sobers up, they can't recall how they got to the doorstep or how long they were there, okay? Substance induced, okay? Sedatives, hypnotics, anxiolytics are more likely to predispose to those things. Anticonvulsants, intrathecal methotrexate, some toxins. So somebody who's exposed to lead or to mercury, carbon monoxide. So they might have these, that might predispose a amnestic period, okay? Somebody gets hospitalized, a carbon monoxide leak in their home, they have this amnestic surrounding period around even though they were alert, they have no recall at that time. There's environmental substances toxins that can cause it. It can be due to a medical condition, head trauma, cerebral anoxia, brain surgery, poorly controlled diabetes, insulin dependent, epilepsy. So somebody with an epileptic seizure, they might not remember the period right before their seizure or during the seizure. Severe migraine can cause an amnestic period. So transient would be considered less than a month so that it improves after that and resolves. And then chronic would be greater than a month. All right, we're going to spend the next 20 minutes of class talking about working with these patients. So practical things that we can do and say, and this is where I'd love to have any input too from anybody that's worked with patients things that they have done that they found helpful. We think about the hostile patient and the agitated patient as being the most difficult to work with because they can harm themselves, they can harm you, it can escalate out of control very quickly. So we call that a catastrophic reaction, okay, where things just escalate. And I think about a situation, it was in the old ER more than a decade ago, and I had a patient, there was no rooms and the patient was out in the middle of the ER on the stretcher. The spouse was there. The spouse was just consolable because his wife of many decades had dementia and had become aggressive and physically hurtful to the patient where he could not handle it at home anymore. So he brought her in for potential for long-term care placement. So when we have a patient like that, we need to first look at, is there a reason for the worsening behavior, the hostility, the agitation? So we do urine samples, this and that, make sure that there's no infection, there's no underlying delirium that's worsening the cognitive status of the patient, right? And so that's the first thing we do. We look for a cause and a reason. So it might require doing a straight cath because you want a clean sample. You don't want to get a false positive and put the patient on antibiotics for no reason. And that can be a challenge in itself. You might need to pull your ER tech in to help you, or another nurse, because the patient might be aggressive, right? They don't want to be catheterized. They don't understand what you're doing. They just know they're being violated, right? So if we can get a regular urine, we do. So we need to rule out delirium. And then, unfortunately, going into long-term care requires a 3-day hospital stay. And to have a 3-day hospital stay, you need a reason for admission, or Medicare won't cover it, right? So you have to really be creative in trying to find some reason for this patient to be hospitalized so that it can then go to long-term care. So unfortunately, that's part of the problem, and why the ED is maybe not the best place always, but it often becomes a place where the patient transitions between home and long-term rehab dementia facility. So that's something that we have to work with. So you have this patient. He arrives in the ED with his wife's reports of worsening confusion, increased agitation, urinary frequency. So right away, that's a key. You do ask about those things. Often it's not said. As you attempt to perform your assessment, the patient swats at you, starts yelling, "Don't touch me." You can see loudly, "Stop, stop." Everybody looks, alarming other patients nearby. What do you do now? So what are things that the nurse, what could have I done when coming into this patient's room? What are some things that I could have done to kind of avert this from happening? What are things that you guys do when you enter a patient's room with dementia that has a tendency for agitation?
Introduce yourself, explain what you're going to do.
Good. Good. So hi, I'm Denise. I'm your nurse. You're here in the emergency room. The safe place. Your husband's, your wife's right here with you, and you don't stand over them and do this. You pull up a chair and you sit down next to them, and you don't start off by touching them before you even say anything, right? So you first get eye contact, you speak calmly, you don't act rushed like you got 50,000 things to do, right? And you take some time with this patient to try to develop a relationship, a therapeutic relationship right away. So anything else?
I don't know, like, in an ED setting when you are in fact rushed, even though you're trying not to be. I know with my great grandmother, who we took care of until she passed away with Alzheimer's, we used distraction a lot. So we would try and sit, and we would try and it takes a little while to get them.
Distraction is huge, and we're going to talk a lot about that in tomorrow. There's a video that talks about redirection. It's kind of not the best video, but it gives you some ideas about redirection. The acting's a little poor, but and there's also it looks at brains, autopsy of brains that show like the parts of the brain that atrophies, and you see the sulci increased. And I know sometimes, especially when I first started in nursing, and I'd have patients who were just mean or agitated, you have to just remember again, or somebody that's swearing at you or being sexually inappropriate, grabbing you, or you have to remember the disease, right? And you can't get angry back, of course. You have to be, you want to continue to be calm and calming. But you do hear and report, how this patient was, sexually inappropriate. It's like they're taking it personally, and you can't do that, right? You have to understand the disease. We are nurses, we understand the pathology behind the disease, that it's the disease acting out, and not this patient who, you know, very kind, totally different in their personality, these changes, right? We have to remember that, okay? And we have to treat them as if they were our family member. It can be difficult, but think about how you would want your parent treated or your family member treated when we're working with these patients. All right, so these are all communication strategies that we can use. The words that we use. We don't want to use like a lot of like slang terms or like jump into bed, let me help you jump into bed. Hey, those types of things become very difficult. You want to do things step by step. Let's stand. Okay, turn toward me. Let's sit down. Okay, so use simple, concrete nouns and positive messages. So you want to always be positive. Be aware of your body language and your mood, because they will pick up on that. And if you're in a hurry, they will pick up on that, and it can make them more restless. So you want to be very calm with them. Get down on their level, eye to eye contact. Approach them from their dominant side if possible. Make sure you verbalize that, you know, you verbally speak before you would ever touch their hand. It is okay to touch them, but once you've developed a trust, so you can touch their hand or their shoulder, but there are times that they're agitated, you may want to refrain from touching them. Although there are times, you know, I have held somebody's hand when they're agitated and it has helped calm them. So you kind of have to use your intuition. You're looking for hidden emotions masked in the patient's words. And I watched the video yesterday. This doctor that has a really good videos on YouTube about communicating. They're for caregivers, but they're also great for nurses. The patient in long-term care that's constantly saying, I want to go home, I want to go home, I want to go home. We see that all the time, patients in the hospital. Get me home, I need to go home, I gotta feed my dog, I need to go home. And they say that repeatedly, okay? And the doctor pointed out that this is often more has to do with not actually going home, although sometimes they do want to go home, but it has to do with repressing more to do with how they're feeling rather than, you know, being at home. So they might be feeling fearful or afraid. So you want to explore the request deeper. You're going to not rationalize why they're there. So your family brought you here to the ER, and or this is a long-term care center. This is your home now. You're not gonna do that. You're gonna further ask questions like, "Tell me about your home. What's your favorite part of your home? Is it your kitchen? What kind of things do you like to cook in your kitchen? Let's have a snack." And then you bring a snack in. Okay, so you redirect them. So similar to what somebody said is you use redirection. Do you like to garden at your home? What you like to just like make vegetables? So let's, and you just kind of turn it around. You have them talk to you about their family. If they still have recollection of their family, they may not. So they may not be able to tell you, but they might, some of that long-term memory, how many kids they had, or, and there might be periods where they can reach in and tap into those memories and other periods where they cannot. So you can try to get them to talk about something, or if you know they like to knit or to do something, you can talk about that and bring that into the conversation, redirect them, and then lead them to another place. So where they're no longer focused on going home. I see nurses sometimes walk with patients in the ED. they go for a walk around the unit. They're there for days waiting for placement or waiting for a bed. I've had a patient come sit with me at the computer. And they weren't looking at the screen, but they would sit with me at the computer while I documented. We didn't have a one-to-one. I need to keep the patient safe. I kept the patient with me at the computer for a short time. So then I would walk with them, go back to the room, and give them something to do. You'll see techs bring them, face cloths to fold, and you'll see them folding all the face cloths in the unit to redirect them. So you find little windows of opportunity when you're talking to them, and then you take those and then redirect them. Avoid pitfalls where you are pulled in to, and you find things escalating. So you don't want to start rationalizing with them. You're not at home. You're here at the hospital. It's not 1922 and John F. Kennedy is not the president right now. It's Joe Biden. So you're not rationalizing ever, finding, and that's why and with new nurses initially you're taught, especially with medication administration, the patient has to say their name and their date of birth, or you're not giving them their medication. They may not be able to tell you their name and date of birth, so you rely on their band. You don't push them to say their date of birth when it's never gonna happen, right? That can escalate their behavior. When my mom didn't have Alzheimer's dementia, but she definitely had some huge amounts of delirium going on in her last months of life. Related to her disease process, but we had a home health care aide who would come in and try to reorient my mom, and it just made my mom agitated. When that aide left, my mom was like, they're never coming in this house again, never ever. And my mom got really agitated. She was embarrassed that she couldn't answer the person's questions. You do not push them when they cannot recall. Think of the brain. The brain is not synapsing. Synapses aren't happening, and you do not rationalize with them. And some people have a hard time. Well, I'm not going to lie to them and tell them, that their dog is here in the room with them, or because they might be hallucinating. They might be seeing things, confabulating things. But we don't feed into the delusion, but we also don't rationalize with them. It can lead to agitation. Okay. So we comfort them just kind of by responding to their emotions. So are you feeling scared or upset? I'm here with you. I'm going to be here with you all night. I'll check on you often. And you do need to then check on them often. So peek in, and if they need reassurance, you're there and you're consistent with that. What are other ways that y'all have found helpful in working with patients with dementia? Any other ideas or things that you found useful?
Not that I found useful, but I just had a question. I noticed at JML that they had a lot of the older, seemingly demented patients carrying baby dolls around with them. Is that a strategy that they were using to help keep them calm?
Holding that baby doll might bring them a lot of comfort and help them feel secure, right? So yeah, and they take care of that baby doll. I saw something, I think not that long ago on TV about that, where they had patients with dementia. Each of them got a baby doll on the unit, and it just totally changed things on the unit. And they really were able to care for that baby like it was a real baby. It was amazing. Another.
I think because I just had my psychotation, And I think, Rebecca, that's why is because they say that people with dementia, they have that motherly instinct still with them. So that kind of comforts them when they see the baby doll. That's one of the things they kind of remember. It's like, we had a patient, I often see him every dementia unit I work, there's a lot of them who have the baby dolls. It's just comfort them, yeah. It's
Yeah.
motherly instinct, which is the one of the big, it's a big part of their life, so it stays with them kind of.
Mhm.
I also think that knowing what they did for work,
Mm.
sometimes they take really pride of what they've done. And they
Yeah.
tell you if somebody joined the army, when they went away, what age were they, and why they did it. And they
Oftentimes
really,
that long-term memory is intact and they love to talk about those things. Yeah, that's a really good idea.
I think definitely music too. Like I had a patient when I worked in memory care who was really, really combative, but if you just started singing with her, she would kind of stop trying to beat you up and just start singing along with you.
Yeah, yeah. Music taps into a part of the brain that they cannot explain. And there was a family member of somebody with dementia who created a podcast, a pod on their iPod, a playlist of the patient's favorite songs. Okay, so the songs that were meaningful to the patient from their whole life. And when the patient listened to their personal playlist, they remembered every word to the song and the music, and it was really helpful in, especially when the patient would be agitated. They could put music on, like this gentleman here in this picture on the slide. It can totally change their whole mood, and they can go from an agitated state to singing and being happy. And there's a period after it. It must stimulate something in the brain. But if you bring family in or you bring somebody in, there's a period after this where they are more reachable. And it's really amazing. There's through this music and memory and now there's programs across the country and the world where you can donate an iPod and they create playlists for patients, and they use music with the personal playlists with the patients, and they use it. And they use this instead of giving them Haldol or giving them Zyprexa or lorazepam. And it's amazing what it can do. So this is a link that you're asked. It's on the clinical for tomorrow from MedSurg Clinical. There's so many resources on here. And there's a video of a gentleman, I forget his name, but he's a gentleman, and it shows him listening to music and singing along with the music and how he was before, non-interactive, mute. And then after he listened to the music, he was able to speak clearly. He lost his nausea and his speech was clear and to the point. And it's like amazing how music can tap into this part of the brain that sometimes bridges our speech and memory. So if you are working in long-term care and you don't have a program like this in place, I would greatly encourage you to bring it into your facility. It's really, really amazing. So family, it just brings a lot of hope to families too. So they might recognize and call their family, their daughter by their name or their son by their name for the first time in years. It's really amazing. So take a look at that site tomorrow in clinical, and there's a lot of great resources on there. And all the sites that I went on now really address COVID and patients with dementia too. So we can talk about that tomorrow in clinical too. I do want to do the post-test real quick again. So it's the same as the pre-test. So we're going to relaunch and we're going to look at your answers this time. Okay, so go ahead and take this again and see if it's a little easier. Give you about 30 more seconds.
Denise, when a resident at a nursing home is brought in and he's still showing like you can have a conversation with him and that person doesn't want to be there, and with time his condition declined really bad, is it because it's a normal development of the disease, or the resident depression can lead them
Yeah.
to get worse?
Yeah. You know, these patients can lose, you know, it's progression of disease most often. It just progresses, and patients, you know, have failure to thrive at the end. It's part of the disease process. Yeah. Okay, I'm going to end polling and let's go over these real quick. All right, the following is considered to be a potential cause of Alzheimer's disease. So we talked about that choline acetyltransferase, COT, how it affects on acetylcholine. Okay.
Denise, I think you have to share the results.
I'm sorry. Thank you. All right. So 6 or 10% of you thought that was true, but it's actually a lack of that CAT, okay, that affects the acetylcholine. And adequate plaques and tangles. So there's plaques and tangles is abnormal. It's too much. It becomes excessive and causes effects on the neurochemical function. So it would not be inadequate. There's too much plaques and tangles. So that's a bad thing to have. Blood-brain barrier and dopamine, that does not have to do with dementia that we know of. We do know that genetic factors play a big role in causation, especially in early onset dementia. So do make sure that you know these main causes. Also make sure you know some characteristics for Lewy body dementia, and that's important. A major difference between delirium and dementia is that delirium always has a cause, okay? It's not typically insidious. There can be some prodromal symptoms of it for some, but it's most often starts more suddenly. Dementia is more insidious and progressive, right? There's always a cause when there's delirium, okay? We have to identify and treat the cause. And that causes are identified often by lab results, diagnostic tests, okay? And it's often fewer meds is better than more meds, right? So we want to identify the cause and treat it versus treat the delirium. All right. True or false? Lifestyle changes have been thought to decrease risk of Alzheimer's dementia. True. So a good Mediterranean diet, exercise, I didn't mention exercise, moderate exercise, all the things that are heart healthy are good for dementia prevention. So there are, and then hearing aids for those with hearing loss, wearing the glasses. So really making sure there's not a lot of sensory deprivation. 4, a client frequently misplaces items, word searches, finds themselves having difficulty understanding a map, okay? They're not worried about it. They joke with their friends about their memory loss. So this behavior is an example of, okay, so there's a couple terms in here that are important. Frequently, okay, versus occasionally. Word searches and finds themselves difficulty understanding a map. There's some visual, spatial, cognitive changes occurring. So this actually has progressed to mild cognitive impairment, okay?
Can I ask a question on this
They
one?
do joke about with their friends still, but what's important are these other concepts, okay? So others are noticing, they're worried about memory loss is also mild cognitive impairment. But I would, because of this frequently from occasional and the difficulty understanding a map, it would put them in the mild cognitive impairment category. Do you know that the stages run a little bit together, right, too? So that's important to know as well.
Can I just say something? I think I'm having trouble differentiating mild cognitive impairment and dementia.
Okay, okay.
So
So let's talk about that.
I
So,
see on the chart where it says like what is what, but I don't know why I'm doing that.
okay, so the big thing and the difference between MCI and dementia, you have those memory issues with both. You can start to have visual spatial, but with dementia, one of the big changes is that you start seeing personality differences. So somebody who's not quite acting themselves, you see behavioral changes, okay? So somebody who's normally very outgoing declines going out for dinner with their friends or meeting up with family, okay? They start being seclusive. So you start seeing these behavioral, some irritability that, they seem irritable when they're normally easygoing. So that is and then it just progresses from there. So the cognitive things will progress, whereas with mild cognitive impairment, I might keep forgetting where I'm putting things fairly often, but I don't progress from there. I don't start putting my keys in the refrigerator. Okay, I just forget where I put them fairly often. So you can do things like organizational strategies to help combat that.
So are we basically, when we're looking at the differentiating between these, we're looking mostly like for test questions on like the adverbs that go with it? So it's like sometimes or frequently or always, or not always. But, okay.
That can help differentiate. Okay.
Professor Denise?
Yes.
So for moderate to severe Alzheimer's disease, can we use a combination of the medication with
Yes, you can. You can. So you can see, because you see that they combine it. So one's for moderate to severe, one's for mild to moderate. So like I said, these stages they can run together. So you can see somebody on both Aricept and Namenda, okay? But it's if you just see Namenda, most likely they're in the moderate to severe stages. If you just see Aricept, most likely they're mild to moderate.
Thank you.
That's a good question, because it's not all cut and dry, right? If you think that these patients you're taking care of, and they might fluctuate from day to day. They might be more lucid one day and then really having difficulty cognitively and behaviorally another day. So the stages kind of just give family an idea of the progression. But you don't hear a nursing report say my patient's in stage 5 dementia, right? They'll say they have dementia, and they should say mild, moderate, or severe. That is minimally what they should say, and then describe some of the behaviors that they noticed. And that's how you would document as well. You would describe behaviors. And then interventions, especially to keep the patient safe. Okay. All right. So hopefully you'll have some good discussion in clinical tomorrow about caring for these patients. Think about, things, experiences that you could share and bring those to clinical, things that you've done in your work with patients with confusion, questions that you have. And as many of all the clinical instructors have experience working with patients in these areas. So. And I know some of you are on a dementia unit, right? So you might want to talk in clinical about, what you learned today that you can correlate with patients that you've cared for in clinical. What stage you think somebody might be in, or what behaviors you saw. Okay. All right. Yes. Say that again, Jillian.
So I see on our schedule for today that we have from 10 to 10:30 the mental health disorders of children and adolescents with LBC. Do we?
Okay, so Professor Van Cott did finish all her content on Monday, so this will be it for today.
Okay, thank you.
You're welcome. Sorry, I should have made that clear at the beginning of the class.
Professor Denise?
Yes.
So for next week clinical, it's been confirmed that we're going in person for whoever who's going in person?
Okay, so so your clinical instructor will be in touch with you, and yeah, so the plan is to go in person, but you're going to confirm that with your clinical instructor.
Thank you.
Okay. All right. Very good. Thank you for your attention and your participation, and I will see you all down the road.
Thank you.
Thank you.
You're welcome. Have a good day, you guys.
Bye.
Bye.